Hello, everyone. Thank you for joining us today. My name is Chris Wickman. This is an event hosted by the Ingham County Bar Association and the Michigan State Bar Attorney Young Lawyers section. I'm on the board of directors of both of them, and we appreciate you being here today. I'm honored to have our speaker here today, Ms. Deb Willard. Ms. Willard has asked me to keep her bio short. She is a supervisor with the Adult Mental Health Services portion of the Clinton, Eaton, Ingham Community Mental Health section, and we're very honored to have her here today. She is a licensed professional counselor and a certified advanced alcohol and drug counselor. I know Ms. Willard from her work and help with the circuit court, adult mental health court, with regards to felony cases and things like that. And I've seen the presentation. I'm super excited to learn a lot, even having worked with some people with mental health issues in the past. I think it's gonna be a great presentation. So appreciate Ms. Willard, you being here, and thank you, everyone. As I said before, this video is being videoed, so put questions in chat and keep video off, and we will ask the questions throughout. Thank you so much.
Right. Thank you, Chris, and thank you to the Bar Association for the invitation, and thank you to you all for just spending your lunch hour with me today. As we get started, I would like for folks to just think about what brought you here today. Why spend this time here learning about mental health and the referral process? We're going to have an opportunity to talk about questions at the end, but sometimes in the beginning, there's something that drew you here. So if you can just take a minute, maybe jot that down. And if it doesn't get addressed throughout the presentation, please be sure that we address that before we end our time together. So I just wanted to share the introduction piece. So yeah, just if you want to go ahead and thank you. So the introduction, I'm going to talk just a little bit about my experience and the perspective that I'm coming from. The reason that I'm doing that is because not everybody comes from maybe the CMH background, and you may have a different view than what I will be presenting today. So we'll talk about that. We're going to do a brief review of mental illnesses and substance use disorders. It will be brief. We're not going to dive down. We're going to leave that to whoever the assessment staff are who would be assessing for mental illness and doing that clinical diagnostic piece. But we do want to hit on some of that as part of our conversation. We'll review a bit about the referral process, screening. We'll talk about assessments, briefly about treatment, and then have that opportunity to take questions. So a little bit about the perspective. We can back up for just a moment, Jess, in the video. So a little bit about my experience. So I began my career in the SUD world, working for a chemical dependency unit. I then transitioned over to community mental health. I have some experience working in our access office, which is our initial referral destination where they'll start. I have some experience working in our Bridges Crisis Unit, which is a crisis residential unit, as well as a crisis response team. 20+ years of my career has really been working with the severe and persistently mentally ill population, coming alongside and supporting them in their recovery. I have a passion for people with co-occurring disorders. It's rare that you just see one or the other. Often it is co-occurring. And again, whether it's helping consumers, building competency in clinicians, advocating for the needs of the people who interface in our community, that's really where my passion is. All right. So we are going today to start with mental health discussion. We want to start, if you get nothing else from this presentation today, two things are, one, the importance of having a conversation and understanding where people have been. And the second is really looking at this question of what has your experience with the mental health system been? In terms of what is your experience with the mental health system been, I asked you kind of reflect on asking those you are supporting that question. And I invite you to also ask yourself, what has your experience with the mental health system been? You may have personal experience with yourself or a loved one. Certainly you have your professional experience as you help support the community. As we learn more about the different mental illnesses and SUD disorders, keeping that in mind will make a difference. So let's start with types of mood disorders. There's various types. 3 of the major ones are major depression. Major depression, or maybe clinical depression, major depressive disorder are some terms that you have used. Bipolar disorder and persistent depressive disorder. We'll spend some time looking at some of the hallmarks for those. I think it's important to remember that each of these have specified symptoms connected. There are biopsychosocial predispositions for them, as well as vulnerabilities and protective factors. As you look at these, many symptoms of mental health disorders can overlap with one another. This is why it's really important that people meet with mental health professionals who are trained in diagnosing. I think back to college, I can remember when we were going through the diagnostic classes, we were so tempted and looking at, oh, well, that sounds like me, or, that sounds like my loved one. And so we really just want to make sure that we're leaving that professional diagnosing to those that are trained in that. You're going to see things like irritability, difficulty with sleep, whether it's the mood disorders and on into even some of the thought disorders. There's aspects that make us more vulnerable to illness. Some of those vulnerabilities could be a genetic predisposition. It could be the environment. Is it a high stress or high emotion? In family psychoed, we talk about the high expressed emotion that can be a vulnerability. Medical conditions, sometimes like thyroid, can be a predisposition, as well as adverse childhood events. There's also protective factors when looking at mental health. People who have a sense of purpose, who feel a connection to the community, folks who participate in expression of gratitude and meaningful activities, as well as having supports in their life and that social interaction. It's really important when we talk about mental illnesses as well that we leave fault and blame out of the equation. Sometimes it's very common for family members to really lean in and, what did I do? Is there something I did? What could have been done differently? And, we really try to look at keeping fault and blame out as that just impedes recovery. So major depression, taking a peek there. Depression is one of the most common mental disorders in the United States. For some individuals, major depression can result in severe impairment that interfere with or limit one's ability to carry out major life functions. And you're going to see that theme throughout as well. When we're calling something a disorder, we are really looking at that disruption, that impairment in their major or core life functions. So major depression, the next slide, you'll see various lists of symptoms, and we'll just let each one of those come into the screen, and I'll let you read through those. Again, that feelings of guilt, difficulty concentration, here's your difficulty with sleeping, appetite, thoughts of suicide, and irritability, to name a few of them. Moving on to bipolar disorder, formerly called manic depressive illness or manic depression. People may be familiar with that. It's a mental disorder that causes unusual shifts in mood, energy, activity levels, concentration, and the ability to carry out those day-to-day activities. So there's 3 types of bipolar disorder. You have your bipolar 1, bipolar 2, and something called cyclothymic disorder. And we'll go ahead into all 3 have involved the clear mood changes, mood, energy, and activity levels. The moods can really range. And each type really has specific time frames and specific symptoms that are associated with differentiating between the 3. The next is a persistent depressive disorder. And so DSM-5, as people will see when you look at the DSM, they drop the Roman numerals and you just have like just the number 5 on there, was really an attempt to try to simplify some of the disorders, some of the names. And this disorder used to be called dysthymia. And so I think that persistent depressive disorder kind of describes it a little bit more clearly. Again, looking at the symptoms there as they come across the screen, you're still seeing that poor appetite, insomnia, the low fatigue, or fatigue, low energy, self-esteem, concentration, you know, and again, you're really looking at the specific symptoms and timeframes that would differentiate this disorder versus something like the major depression. Next is just looking at some anxiety disorders. So you've got your generalized anxiety disorder, your social anxiety, social phobias, your panic disorders, obsessive compulsive disorders, and things like your post-traumatic disorders will fall under this anxiety category. People with an anxiety disorder do display excessive anxiety or worry. And again, you've got that time frame, most days for at least 6 months, about a number of things such as personal health, work, social interactions, and everyday routine or life circumstances. This is really talking about the generalized anxiety. And again, you have to have that those symptoms have the significant problems in your major life areas. And here are some of the symptoms for your generalized anxiety disorder. Again, that feeling restless. Again, you see the irritability piece come up again. Muscle tension, feelings of worry. Moving from the anxiety disorders, I wanted to talk a little bit about thought disorders. Thought disorders may also be called brain disorders because there is a lot that is happening in the brain. So you have several different thought disorders: schizophrenia, schizoaffective disorder, probably 2 of the more common ones that you see, schizophreniform, your delusional disorder, brief psychotic disorder, and your unspecified schizophrenia spectrum and other psychotic, which is really talking about symptoms that don't meet full criteria for the other disorders. And then, of course, we have our substance-induced psychotic disorder. I think one of the questions we get a lot is, well, how do you know the difference? Was it substance-induced? Is it, you know, schizophrenia? And certainly we need a longitudinal perspective with assessing what might be contributing to that thought disorder. So I'm going to focus today on the schizophrenia and schizoaffective disorder. And with these disorders, kind of the hallmarks for them are what we call positive symptoms and what we call negative symptoms. So the positive symptoms, not to be confused with, yay, this is something positive happening in their life, right? But it's the positive symptoms, the things that are showing up. And so things like your hallucinations, you're hearing voices, seeing things, maybe tactile hallucinations, delusions, which are firmly held beliefs, not supported by objective facts. It could be disorganized speech. So those are some examples of your positive symptoms. The negative symptoms are things that are not happening, right? So the reduced motivation, the difficulty with planning, beginning and sustaining activities, diminished feelings of pleasure in everyday life, that flat affect, maybe some reduced speaking. Usually schizophrenia, many people seem to have their first episode early in life, usually around age 22. When you think back to the vulnerabilities and that stress, think about what's going on in people's lives in early adulthood, where maybe people are going off to college. Maybe people are having children, and that may be some stressors in their environment. We kind of talk about kind of flips the switch for that thought disorders. Positive symptoms, if we can go back for just a moment. So for positive symptoms, just to recognize that we can still, even with medication, you can experience those positive symptoms. So just because somebody's taking medications does not mean that all the symptoms will go away. Certainly that's the goal. The other piece is just a little bit about the negative symptoms that I want to talk about, because this is the part that can take a little bit longer. Oftentimes with medication, we can address those positives, but that planning that it takes, that organization in people's lives. And you really see this when somebody's involved in the legal system. Think about what we are asking of people. Maybe probation requirements. You know, we certainly have timeframes that we need things to be completed in. And for somebody who's really struggling with those negative symptoms of this brain disorder, can really struggle in that area. And it's not that people are purposefully not wanting to follow through, or I'm sure that you all have folks that may do that. But we need to keep this in mind as well in setting those proximal and distal goals when working with folks in the legal system as well. Also, lack of insight. Lack of insight oftentimes can be part of this. And as it being a symptom, that insight can take a long time to occur. And for some people, that lack of insight stays throughout their illness. So shifting to our substance use disorders, I love this slide. Things ranging from alcohol to stimulants, right? Alcohol being a depressant, you see it kind of grayed out there, and stimulants, again, being very stimulating. I love that it's that kind of that brighter color. You will notice that caffeine is on the list. Yes, I'm sorry to break it to folks with their caffeine addictions, but certainly caffeine can be a substance use disorder. All right, so let's look at these a little bit more closely. So I'm going to share with you how I learned about substance use disorders back in 1994 when I was working on an inpatient unit. So we talked about things like increased tolerance, right? So we're going to go over these criteria. So increased tolerance is really about needing more of the substance to get the desired effect, and or the same amount no longer has the same effect on you. So for instance, if you take alcohol, some people I can remember will say, you know, Deb, nope, you know, I don't have increased tolerance. You know, I drink a pint a day. I've always drank a pint a day, and it's just not a problem for me. So therefore, I don't have a substance use disorder. And sometimes the follow-up questions are really important. It goes back to that, how do you have that conversation with someone? So I follow up with, well, does that pint do the same thing for you today that it did for you maybe last year or 2 years ago? And oftentimes the response is, well, no, it doesn't. Caffeine can also have that increased tolerance as well. So withdrawal symptoms is the next piece. And I think maybe I'll bring these through each one. So we've got increased tolerance, withdrawal symptoms, this idea of loss of control, and the psychological part of addiction. So withdrawal is really the body's response to no longer having the substance in your system. So usually what you will see is that the substance has a certain effect. So let's take alcohol. Alcohol is a depressant. It tends to slow people down. In withdrawal, people with alcohol, they tend to have increased heart rate, increased blood pressure. You'll see things like people having the shakes. Withdrawals and intoxication when you're looking at something like heroin. So what does heroin do? Heroin, really sometimes the goal with heroin is for people to cop a nod. And that sometimes is that really close to death, right? Is kind of that goal. And so that is the effect. Sometimes when people are using opiates, they may have things like constipation. So if you ever have been prescribed maybe for pain following a surgery, you know, they'll talk about constipation with the prescribed pain medication. So in withdrawal, what we tend to see are things like people are more anxious. People, instead of experiencing the constipation, will also, during those withdrawals, they will have things like diarrhea, vomiting, those types of symptoms, things, flu-like symptoms. Loss of control, again, is using more of the substance than you intended to, or that inability to stop your use. So again, that loss of control may be, I'm going to go out tonight, I'm only going to have one drink, right? And then, because we're thinking I'm going to be able to control my use, but I go out and then I end up just getting, you know, totally intoxicated, you know, 5, 6 beers later, right? So that's, I'm using more than I intended to. The other is psychological. So the psychological piece is, I like the effect something has on me well enough, I do it again. If we stop there, we don't have the psychological part of addiction. You really need that last part, in spite of the known consequences. Something to note in terms of physical dependence, not everybody who has that tolerance and withdrawal is considered to have a substance use disorder. Again, if you are prescribed medication for pain, you may have that dependence, physiological dependence. And so we need to be very careful to call that a substance use disorder. That's how the medication is designed. I want to talk a little bit about stages of change next. So many of you have probably heard about stages of change. Stages of change can be really used for anything. It's not just for the SUD world. It can be used for mental health and really kind of any area that you think needs a change in your life. So I'm going to briefly describe them. So pre-contemplation, summarizing, pre-contemplation is this attitude of problem, what problem? Right? I don't see a problem here. Other people may, but I don't. Contemplation are people who are in that stage of, you know, there might be a problem. I don't know. Maybe I'm willing to explore and consider it. I don't know that I'm going to do anything about it yet. But the kind of that may be, I'm willing to contemplate that. Preparation is people getting ready to take some action. They're saying, yep, I've contemplated it, like I've explored that. I think I'm ready to move forward. Action is really the person attempting to make those changes. They are making those. They're avoiding situations that may trigger a recurrence of the symptoms, whether it's that substance use or mental health symptoms. Maintenance is really, they've made the change. They're having success with that. And really their focus now is looking at preventing relapse. And then certainly this number 6 years relapse, and relapse can occur at any stage. I think it's important with stages of change to really think about when you are coming alongside folks is what stage are they in? Because as you're trying to refer people for treatment, if somebody's in contemplation, you're probably going to experience some resistance in making that referral. And so the words you choose, how you approach it can really make a difference. Recovery. So I really love this picture. It really is about a road to recovery. There's more than one pathway to recovery. What works for one person may not work for the other. Though this picture suggests that recovery is a linear road, we know that it's more like a windy path, and you may not always know what's around the corner. As we move forward and focus our attention on referrals, certainly there's various kinds of referrals that may be made. Certainly in the mental health system, there's urgent and emergent referrals that may warrant referrals to places like our crisis services, maybe emergency rooms, crisis residential units, hospitalization, if we're feeling that someone is in a danger of harming themselves or someone else. And then we look at some non-emergent. That's where you're using your access offices. Maybe we're thinking somebody needs an outpatient service or an intensive outpatient. And we're going to talk about some of the different referrals and where to go next, some of those screening tools as we move forward. When making a referral, it's really helpful to utilize the consent to share. So the state has a standard consent to share for behavioral health information. It is located on the MDHHS website. We've provided that link here for you. If you are wanting to obtain information from a provider, it's really important to, or really helpful if you actually have this consent to share filled out. Otherwise, we have to do that little song and dance of I can't admit or deny that we know who the person is. It's also really helpful if when you're making that referral to make sure that the form is filled out completely. Sometimes I receive these and they're missing some of the required information to make it a valid consent. So keep that in mind as well. Just wanted to give you guys a little bit of a picture of what that looks like. Right, so mental health screening. So screening comes in various forms, right? We can have formal screening tools. Sometimes there's telephone screening prior to scheduling appointments, much like our access office, or maybe when you're getting into an SUD provider, maybe a detox or a residential program. And there's also pre-screenings for things like crisis units or hospitalization, which really falls, even though that screen is in the title, it really does fall more over a formal evaluation or an assessment. And then we'll kind of walk through these a little bit more. So here's information about our access office. So every CMH has some type of central access point. Ours is creatively called Access Center. Here's the contact information for those of you who are in the Clinton, Eaton, and Ingham tri-county area. Usually with these types of screenings, people are asked several questions regarding their needs and their treatment history. When you're making a referral, it's really helpful to prep the person about that process, that it will be by telephone, that it and helping them to get access to a telephone is important as well. But letting them know that there's a series of questions. And I think that, you know, sometimes when folks are at a point of needing help, being asked a series of questions can be frustrating for them. So kind of knowing ahead of time can really help that person to maybe utilize some of their patience during that time. If it's somebody that you feel is just really, remember irritability, we talked about that a lot in the disorders. If the person is really irritable and might get more frustrated with that and feel like it's more of an interrogation, I think that, you know, coming alongside them and maybe making that phone call with them, if you have the capacity and the time to be able to do that, is very helpful. Usually it's about 20 minutes. And usually it goes pretty smoothly. Following that, they will usually be given, if they meet criteria for an assessment, they would be given an appointment. So oftentimes I get questions about insurance. So I wanted to share that CEI is one of the certified community behavioral health clinic. We've been awarded a grant as we are looking to become certified in this area. What this has allowed us to do is to be able to expand access to care, increase our care coordination and quality of service, and this is a SAMHSA grant. So it does allow us at this time to offer some of our specialty services to people who qualify for them. You know, certainly we serve folks who are uninsured, the Medicaid population. This does also help us to, again, for specialty services, help those with who are commercially insured. So these are our target populations. Again, we're looking at the severity of the illness. If you have somebody with private insurance, I always recommend that they take a look at their insurance card. On the back of the card is a customer service number. You call that customer service number and ask for providers. It's helpful to ask for the in-network providers versus the out-of-network. It usually helps people with the cost, the in-network, just like with your medical care. Is usually a cost savings to you. And then they have the list of providers. Sometimes there's websites that you can go to where they have the provider directory tools as well. Wanted to give a little tip about medication for those folks who maybe are struggling with obtaining medication in the community if it's not covered by insurance. There are some prescription assistance programs that pharmaceutical companies can assist with. So if somebody is prescribed medication, certainly knowing what that medication is, who the maker of that medication, and then getting online and looking up the patient assistance. Also, pharmacies can also assist with that and maybe getting connected. We have Ascension Pharmacy here in our main Jolly Road building. And if people inquire about the patient assistance programs, we do have staff in the pharmacy who can assist with that. So moving along with screenings, here's just a couple examples of some screening tools. So we have the PCL5 and the PHQ-9. These are two that we use here at CEI. I think they are used pretty widely across the state and other programs as well. So the PCL5 is a trauma screening. The PHQ-9 for depression. The PHQ-9 might look familiar to you. If anybody has been to their primary care doctor, they will have seen, probably been handed this on a clipboard for your annual depression screening in that setting. There's also the GAD-7 for anxiety. There's many different tools. Substance use disorder screenings, here's a couple. We have the CAGE-8 and we have the UNCOPE. I won't read through all of these, but again, you're looking at just ways to be able to have that conversation, whether it's you're formally asking the questions and how you ask them, but you'll see things like, you know, the C's. Have you ever thought you ought to cut down? So C is for the cut down on your drinking or drug use. There's the CAGE for alcohol. CAGE-8 adds the drugs, other drugs categories to that. And so you'll see, remember in the beginning when we talked about kind of those questions about the psychological, the withdrawal, loss of control, each of these questions gets you to that information. The UNCOPE is what we use here at CEI, and I think there's other CMHs around the state who use the UNCOPE within their formal assessment process. All right, so the next piece with, I wanted, before we move back from screening, so on our CMH website, we do have a behavioral health screening that if you go to that and click on the behavioral health screening, there's a general one. If people aren't sure, they just know they're having some symptoms, they can fill that out. There's some that are specific to things like depression and so forth. And so I encourage folks to maybe check that out, maybe take that screening yourself and just explore some of the different options that link has in terms of linking to various screenings. So QPR stands for question, persuade, refer. I wanted to share this with you all because it's an opportunity that you would have to take this training. It's an hour-long training, really focused on if you believe that maybe somebody's struggling with some suicidal thoughts, it's a way to engage with them and help connect them to the help. And so you'll see there's a wellness, prevention and wellness specialist here at CMH. Their number is 517-887-5232. If you are interested in receiving such training. The other training opportunity for those of you who may be interested is mental health first aid. Mental health first aid, similar to physical first aid, right? Is when you're seeing some symptoms, you know, what do you do? And so we have some public trainings that are coming up this year. Those dates are listed there on your screen. There is a small cost to that. Primarily that's to cover the training materials. And there again is a link to our website in order to register if that's something that you're interested in. When I get feedback from people who have attended the mental health first aid training, I get very positive feedback that people find it very, very helpful and very empowering to be able to have those conversations and assist someone to get to help. The next section we're going to talk about is assessment. And again, with assessments, there is a whole host of assessments, right? You've got your biopsychosocial assessments. Most CMHs will use a biopsychosocial assessment approach. We're looking at what are the medical factors, what are the psychological, as well as the social impacts that's happening in somebody's life. You have your substance use disorder assessment. Here at CEI, we try to, in our biopsychosocial, always cover the SUD portion because again, more people than not have co-occurring disorders. The substance use disorder assessment and the substance use evaluation assessment are two different things. Many of you here are probably familiar with the substance use evaluation, which is more, that's used when people are trying to get their license back, right? They maybe have had the drunk driving and they're trying to work with Secretary of State. Not all SUD providers provide the service to complete the form, the paperwork for the substance use evaluation. There's usually a separate expense and fee that is usually charged for that, given the paperwork and the form completion and submission that's involved with that. I could probably turn it over to Chris. Chris, did you have anything to add as far as any of the substance use and the driver's license evaluation?
Nope. So there's a substance abuse evaluation. I think anyone who does some criminal work is familiar with. There's also a separate one for driver's license. So there's a lot of uses to these evaluations, various different evaluations. I know specifically in the criminal context and things like that, and abuse and neglect. If anyone is looking for referrals or wants to discuss possible evaluations in the specifically criminal context, but in the court context, feel free to reach out to me afterwards. I'm happy to help with that as well. Thank you, Deb.
You're welcome. Thank you. The next kind of assessment is your clinical certification evaluation. Those are the clinical certs are part of the involuntary process when someone's involved with a person requiring treatment, right? A PRT, or as we tend to look at it from the mental health side, you're going to be completing a petition or an application for treatment. And the clinical certs and the EDs, certainly, the ED physicians can do that, but usually your psychologist and most definitely a psychiatrist is involved in that process. Forensics evaluation, again, you all are probably more familiar with Center for Forensics. I did put this on this list because sometimes somebody may not be involved with Center for Forensics, but there may be a request for a forensics style evaluation. And it's just important to know that not all psychiatrists are trained forensically. To be able to do those types of evaluations. There are some across the state who may be willing to do that if that's something that's needed. So I just wanted to separate that piece out. Same thing with competency evaluations. So there's competency in the terms of, is this person competent to stand trial? And those determinations are made by the Center for Forensics. There's also competencies in terms of, is this person competent to make decisions for themselves, or do we need to move forward in terms of somebody, does somebody need a guardian, right? And then when we're looking at the competence with that, usually a psychiatrist would be involved in that recommendation. And we can certainly petition probate if we feel that there is a guardianship may be needed. Family members can also work with probate on the guardianship piece as well. And then you have your psychiatric evaluation. It's important to note that mental health professionals, we do some sort of assessment at every clinical visit. whether we're assessing for mental status or maybe we're noticing some changes in functioning. Maybe we're getting some indicators that we need to ask about suicide or homicidal risk, as well as insight and judgment. So again, it's done kind of informally, maybe not in writing, but we're always thinking and assessing. I have the next slide in terms of 3 different tools or instruments that can be used. And I liked putting these side by side to see that we all may have a different view of how we're looking for information. And we are also looking at the same types of things. So here are the 3 examples. The Locus is a level of care utilization system. This was created by the Association of Community Psychiatrists. Again, you're going to see that function status, what are the symptoms, what is the recovery environment. ASAM, ASAM is the American Society of Addiction Medicine. This is the tool that's used for placement, continued stays, discharge planning for people who are in the SUD system of care. You may hear some things like this person doesn't meet criteria for detox, or they meet criteria for residential, or they don't meet criteria for residential. This is the tool that they're looking at, and there's the 6 dimensions. I added the criminogenic needs because we talk a lot about this in our specialty courts. Certainly things like the compass is a tool that is used in many probation departments. And again, we're looking at these different factors to see what programming do we need to try to address that criminal thinking. What are the needs out there? Again, I like the commonality. If we have a different view, but often looking at the same or similar symptoms. The next slide is really, I developed this because I needed a tool when we were talking about our services in adult mental health here at CEI, that we really serve kind of that mild, moderate population up to the severe and persistent population. And I hope that you find it somewhat helpful. It is a bit of a complicated slide. I apologize for some of you maybe who are have a smaller screen and might have some difficulty in seeing it. But I just wanted to walk through a bit. So we have our wellness programs here located at our various sites throughout the Tri-County area. And really, this is your outpatient counseling, right? This is serving those folks with a major depressive disorder, that persistent depressive disorder, your anxiety disorder, some trauma. People are seen 1 to 4 times per month. It's important to know in our community here at CMH and our wellness programs, we do not have psychiatry services in those programs. We rely heavily on primary care because many of depression, anxiety may be able to be treated at that primary care level. We have our case management services, and this is for folks with a serious mental illness. This is where you see a lot of the bipolar disorder, those thought disorders, schizophrenia, schizoaffective disorder. They're generally seen 1 to 4 times per month. People in this category of service may live independently. They may live in a residential setting. Psychiatry services are available, they're needed. There's usually a team involved, including nurses. And again, we see people who live independently as well as maybe in adult foster care as well. Our highest level of care for people living independently is our assertive community treatment. And this is really a program when the deinstitutionalization movement took place. They're really trying to give people the supports necessary to be able to live in and among the community. That highest level of care, people are seeing up to daily, sometimes a couple of times a day, depending on their medication schedule. Psychiatry is very much a part of the team. And 90% of the services are out in the community. It is not an office-based service. And here at CEI, we have this outreach case management that's kind of that in between case management and assertive community treatment, meeting the needs of the severe and persistent. To the left, we have certainly the short-term case management. That's when we just kind of can't figure it out, right? So, what came first, the chicken or the egg? Does this person need to be referred to an SUD program or a mental health program? We're trying to figure that piece out, or maybe they just have some short-term needs that can be resolved, and then we can then pass the baton to someone in the community or maybe a lower level of care. Our young adult services, this is still under construction, really looking at folks who are transitioning out of youth services programs and into independent living, really focused on that kind of 18 to 21-year-old population. Just important to note that we do serve 18 to 21-year-olds in all of our other levels of care as well. A note on the bottom just about hospitalization, and that can occur throughout the continuum. Certainly we have our Bridges Crisis Unit, which is our crisis residential. We have a program for veterans, our crisis services, our urgent care and mobile crisis services for acute situations. And again, any of that can happen along that level of care. Some cool things about mobile crisis is we continue to expand that program. We do have, we've started a pilot project with Meridian Police Department where they will have some type of an iPad, and when law enforcement responds to a mental health call, they can use that technology to connect with one of our therapists that is located here in Jolly Road in our crisis services. Kind of the goal is within that 15 minutes to decide kind of what next steps, what needs to happen. If the scene can be secured, do we need to send up mobile crisis staff out there and, police can leave and then we follow up? Maybe, is there a situation where the person needs to be PRT'd and brought into our crisis services? It is important to note with our crisis services, we do have a standalone facility here. There are some situations where we do have to have folks go through the emergency department. We are not able to physically restrain people here in crisis services, either physically or through chemical restraints. And so that I think sometimes people get confused of, hey, why'd you have to send them to the ED? And sometimes one of those two situations may be occurring. Also, people get sent after they have been evaluated at crisis services, they may get sent to the ED for medical clearance if psychiatric hospitalization is being sought. Some cool things for folks to know. In McLaren Emergency Department, we do have a CMH staff that's located in the emergency room to assist the medical staff there with mental health crises. Some other things, if folks go to the ED, I don't know how many people are aware of Sparrow. They have an actual behavioral health unit embedded in their emergency department. It's called Section E. So oftentimes once someone is waiting for hospitalization, it's an area that's just, it's less stimulating. Emergency departments, they can be loud. There's a lot of equipment. So the Section E is really a place where people can go and, especially if you've got pacers, you can't pace in an emergency department hallway, but in Section E, people are allowed to kind of get up and walk around a little bit as they are awaiting psychiatric placement. So you may hear some about that if you're supporting someone who is seeking hospitalization. So just in closing, I know that our time is getting short and we've really just been covering a lot of things very rapidly here. It's really important to just remember that support that offers hope is vital throughout the recovery journey. So Joyce Berlin, she's the NAMI Family to Family originator. NAMI stands for National Alliance on Mental Illness. She has a statement of mental illness is the only illness for which no one ever brings you a covered casserole. I just want that to sink in for a moment. Some of you may have heard about the no casserole illnesses. So when somebody is sick and they have a hospitalization, people in the community are usually rallying around them, right? When they go back home, maybe family or other supports, neighbors are bringing food over, right? To welcome you home and to kind of help you with that transition. Churches are getting the meal trains going. When somebody goes into a psychiatric hospital or an SUD, program, these are illnesses when people come out that support is missing. And so I think this just really challenges that stigma that is still alive and well in our communities for both mental health and SUD. The other is just remember what we talked about in the beginning, that what has your experience with the mental health system been, can really help you, guide you through conversations. You know, I don't know if folks have seen maybe the HBO documentary, the Ernie and Joe Crisis Cops. I know NAMI put on an event recently, and Ernie Stevens was highlighted on the local news here. And I think about that one scene, and again, I encourage you to watch the documentary, where there's a woman and she's getting ready to jump over the bridge, right? And so Ernie and Joe show up, and as they're approaching her, right, cautiously, she's saying things to them like, "Don't come near me. You're gonna grab me. Don't tase me." She's saying those things probably for a reason, because those things that she's asking them not to do have probably either happened to her or somebody that she knows. And so as we enter this, this experience, some people love us, right? They're like, "Hey, CMH, you know, you really helped me through all this." And other people are like, "No, you know, that intervention didn't go so well." And so again, just that sensitivity as we move forward, again, looking at that support and that hope really sets the stage. All right, so we are at that time. What questions do you have? Certainly think back to maybe what you wrote down in the beginning of what brought you here today. I want to make sure that we are able to address that. It looks like we've got a few minutes to be able to do that. Chris, I'll kind of look to you. I think people have been entering those questions in the chat.
All right, everyone go ahead and remember that you can put the question in the chat or private message me and I'll ask it on your behalf. We did have one question to get us started. Someone commented to me that they have a friend in their early 70s and their adult son lives with her. He cannot and does not work. Does not contribute. He does need mental health therapy or assistance, but he will not seek such on his own or continue on his own when he has had opportunities. The friend feels lost with regards to getting help. You know, what would you suggest as far as options to go, you know, are available for that individual?
Absolutely. So there's probably a multi-layered answers to the question. So a couple things. One is NAMI, so National Alliance on Mental Illness. If I don't know if that's local here, we have a very strong NAMI presence in our community. There's NAMI Lansing and NAMI of Michigan. NAMI is a grassroots program. So maybe encouraging the 70-year-old to reach out to NAMI for support. They have a family to families program and other services that they could share to be able to come alongside your friend who is trying to support their adult son. The other piece is certainly, you know, we didn't have a lot of time to talk about alternative treatment orders. So if this is a person who is requiring treatment that has difficulty functioning, you can certainly pursue that. Anyone 18 or over can petition for an outpatient order, a Kevin's Law. And so probate has information related to that. Certainly that person, maybe they would like to reach out to their local CMH to ask for some assistance and some direction. Certainly if that person does have a mental illness that needs to be treated, we always try to do that voluntarily as best we can. Things usually go smoother in that. But we know that doesn't always take place. So I would reach out to that access center for the resources in your community, as well as NAMI.
Okay, and just for people's knowledge, for who haven't interacted with the consenting and the voluntary aspect of it, something that might start as possibly going voluntary can sometimes turn
Yes.
voluntary. because there are benefits to the participant participating voluntarily that aren't available involuntary. So I think those are great resources and great referrals. And to clarify, the mother of the person can also contact Access as far as a starting point with regards to that?
Yeah. So she could start
Or
to
did-
say, I'm not sure where to go. This is what's going on. And then Access can try. Access would not be able to schedule an appointment for the son. They have to talk to the person or to the guardian in order to schedule the appointment. But sometimes you don't know where to go. And usually your CMHs can assist with that. There's certainly lots of other follow-up questions that may be needed in terms of, how old the son is, what symptoms are they experiencing, those types of things. I will have my phone number at the end of the presentation, and the person asking the question, if you want to talk more directly about that, especially, if you're here in our Tri-County area, I would be happy to assist further with that question.
Thank you very much. Another question that was in the chat is referrals seem to be for low income, correct?
So when we say referrals for low income, so I guess it depends on what we're referring to. So if you're referring to community mental health, certainly that is our priority population. However, with the CCBHC, we are able to see people who have private insurance. So it just depends on if they meet that specialty criteria. I don't know if the person who asked the question maybe could be a little bit more specific about the referral destination.
Okay. And if that person wants to go ahead and speak up in the chat, they're welcome to do so. I think you've kind of pointed out that a lot of information you can get from customer service with private insurance, or you can contact Access and do it as a central point. Did other individuals have questions? We have another couple minutes here. Did anyone else have questions? Or if you're thinking back and reflecting on why you attended, do you have answers that you were looking for and things like that? So feel free to put them in chat, or if individuals wanted to unmute for this purpose to ask a question, they can do so. Just remember, we are videoing, so if you're going to be shy, put them in chat. All right, I'm not seeing any right now, but people might be typing them. Deb, did you have, there was a question about ethics issues about advising therapy. So I'm going to go ahead and address that. I think what the individual is asking about is when is it appropriate, or are there concerns as an attorney with regards to advising therapy and things like that. I think that it could be very ethically complicated to do a referral for involuntary services and things like that, relying on client secrets, client advice. Now, there is a Michigan rule of professional conduct specifically addressing, when you can help a client who's unable to help themselves. And there are some rules on that, and you can always contact the ethics hotline or consult the rules of professional conduct. With regards to advising therapy, I think it largely depends on the relationship that you have with the client and why you are seeking that. In the criminal context, I always want to be a counselor to my clients. Plain and simple, the healthier my client mental state is, the better off it is for us going forward. I know in some other practice areas, such as family law, sometimes it is helpful to have a person stabilized in order to have short and long-term goals. Now, practice area by practice area, it might differ with regards to that. And if the person wants to contact me via email, I can help to explore those issues, or at least point you to ethics opinions and things like that. We have to be careful with our client secrets and things, but I don't ever consider it outside my job to try to put my client in the best position possible. And I think that mental health is a part of that. Same as if you had a client who said, I'm bleeding out of my head, I imagine you'd say, go to a doctor. And I don't know that mental health needs to be that much different. And having the right conversation and helping to remove the stigma of mental health counseling or treatment as the attorney can often be tremendously helpful for the client and put them in a better position. I am not seeing any other questions, Deb. I'll turn it over to you. Any final thoughts that you wanted to make?
I just wanted to say thank you for your participating and being with me here today. I appreciated our time. I'm glad that we're able to adjust to kind of this virtual world right now. It'd be much better if we could all be together and interacting that way. But again, don't hesitate. If you do have additional questions, please contact me by email or by phone. Certainly the involuntary process, whether it's an initial treatment order or the Kevin's Law, there's different pathways for that that sometimes can be confusing at times. So certainly, reaching out to your local CMH if you're not in this area as well. I know our crisis services, if you find yourself in that, kind of urgent situation, you can always call them and they can help with that next step as well. So again, thank you for your time, and I hope you all have a great rest of the afternoon.
Thank you so much, Deb. I appreciate everyone being here and sticking it out with us. I hope that people have learned a lot. I know that I have, and obviously, no one's immune from this. So attorneys, if you see anything specific that rings true maybe in your own behaviors, I hope that you'll be an example and also reach out as well. And there's a great list of resources. So thank you so much, Deb, and thank you so much for attending today. Any questions, feel free to reach out to me or Deb, and we'll go ahead and stop the recording.